So welcome back, everyone. I am very happy to introduce our next speaker, Dr. Laura Bogart. Dr. Bogart is a senior behavioral scientist at the RAND Corporation and a member of the Pardee RAND graduate school faculty. He's also a social psychologist specializing in community-based participatory research to understand and address health disparities. And I should also say that Dr. Bogart has been a very active member of the planning committee. She's basically been the co-course director. And so I really appreciate all of her contributions to this effort. Dr. Bogart.
Thank you very much for the great introduction. And so today I'm going to be talking about medical mistrust and discrimination in healthcare provision in Black communities, and specifically recommendations for providers. So before I get started, I just wanted to mention my collaborators throughout this journey of all of my work on this. And first, I'd like to mention Dr. Billy Cunningham, the late Dr. Billy Cunningham, who unfortunately passed away earlier this year. And he's a true mentor and dear collaborator across decades of research on this with me. And he was a physician researcher at UCLA and a very great mentor. Also, Dr. Lulu Dong, who's at RAND with me. She's a clinical psychologist, and a lot of the strategies I'll be presenting today I discussed with her, and she contributed to. Dr. Basola Ojikutu at Harvard Medical School, also a physician researcher, infectious disease specialist, who has done a lot of work with me on medical mistrust. And finally, Dr. Sai Takata, a physician researcher at UCLA, and you'll be hearing from her later in this presentation. And both Lulu and Sai are on the planning committee as well. So first, I'll give a bit of a background about medical mistrust and talk about the contribution of mistrust to health outcomes. Already you've heard some excellent presentations on this today, but I'll just cover a bit about my perspective and some of the specific research I've done on the topic. And then I'll give some recommendations and focus most of my time on recommendations for healthcare providers. But I'd also want to talk a little bit about healthcare organizations and communities and around structural change. So what's medical mistrust? You've already heard an excellent definition from Dr. Blackstock. But just again to reiterate, it's distrust of healthcare systems, providers, and treatment. It's the absence of trust that providers and organizations generally care for patients' interests, are honest, practice confidentiality, and have confidence to produce the best achievable results. So again, as you've already heard, discrimination leads to mistrust, but I do feel like I need to reiterate that, because whenever we talk about mistrust in any context, it's really important to talk about the origins, and they always need to be linked in our discussions. So among Black Americans, high levels of medical mistrust are a response to historical injustices, unethical medical experimentation, as you've heard about, dating from the time back to slavery. Have a picture of the Tuskegee syphilis study here, and as well as ongoing current discrimination, including systemic racism that exists today. And research on my own and others have found that people who experience interpersonal discrimination from other people have higher levels of mistrust, and also as well as discrimination within healthcare with their providers. And mistrust explains the association between discrimination and health behaviors. So it's a mediator between discrimination and health behaviors. So people who experience discrimination have higher levels of mistrust, and that in turn leads to a longer time, for example, since their last medical exam and non-adherence to treatment. So I also want to discuss how I think of mistrust and conceptualize it. And I think of mistrust as a form of resilience. And a lot of times we think about, how can we reduce mistrust? And it's really about how can we address mistrust and have the conversation about it? Because mistrust is not necessarily harmful. We shouldn't always think about it as a negative. It's very natural that people would want to put their guard up after so much discrimination and experiencing so much systemic racism. And it's actually something that can empower individuals to change and for societal change when it's channeled effectively. So mistrust can be thought of as a protective or an adaptive survival mechanism in the face of oppression. And that means it can be a healthy, functional coping mechanism. And of course, sometimes mistrust can lead to things like not going to the doctor, and that can be an issue. But we should talk about mistrust as something that arose as a healthy functioning coping mechanism for survival. So I'd like to give some examples of mistrust from my own research. So I've studied things like HIV and COVID-19 related mistrust, and I'll talk a little bit about those studies in the next slides. They've also been called conspiracy beliefs, but I've tried to stray away from that term because people might see it as pejorative. Although I do want to say they're not necessarily false, harmful, unjustified, or irrational. It's just a term to talk about people who think there's some unknown, active, powerful players who are behind some of these issues. And that could be true, you know, or it could be untrue. So we're not passing a value judgment on them. But these kinds of mistrust also, as I said, called conspiracy beliefs, are mistrust around the origin, prevention, and treatment of HIV or COVID-19, and also other diseases, but that's what I've focused on. So some of these beliefs are HIV was created by the government, or antiretroviral therapy is poison or ineffective, COVID-19 is man-made, for example, is a new belief, or a cure for whatever, it could be HIV, COVID-19, or something else, is being withheld from the poor or from Black people. And I have an example here, Magic Johnson. One belief that we've heard is that, you know, Magic Johnson has the cure, but it's not available to poor people or people like us. So mistrust is common among Black Americans, as we've talked about already, for obvious reasons. In 2016, I did a survey with my colleague, Dr. Basolo Ojikutu, who I mentioned, National Survey of HIV in the Black Community. And we found prevalent beliefs around HIV and mistrust, including HIV is a man-made virus by a third. There's a cure for HIV being withheld from the poor, around 40%. A third saying medicine that doctors prescribe to treat HIV is poison, and 18% would endorse this basically trust belief. The government usually tells the truth about major health issues. So that means over 80% thought that the government does not. And that was in 2016, and we've seen, you know, this mistrust of the government is likely increasing. So recently with colleagues at APLA Health, I did a study of COVID-19 related mistrust among HIV positive Black adults in LA County. And we've also found prevalent mistrust related beliefs, not surprisingly given our conversation today. For example, COVID-19 is man-made. Half of the sample thought that. A lot of information about COVID-19 is being held back from the government, 63%. The government can't be trusted to tell the truth about COVID-19, 60%. And then finally, 20% said Black people can't trust healthcare providers when it comes to COVID-19. And so 20% is still a lot, a fifth, but it also shows that these beliefs about the government not being trusted are much more prevalent than the beliefs about healthcare providers not being trusted. And so this shows us an opening as healthcare providers. So to think of, well, maybe there is a little trust there that we can build on. We also asked about vaccine hesitancy or mistrust of a future vaccine for COVID, and found that half the sample was worried that a vaccine could be harmful, a third wouldn't trust it, and a third wouldn't want to take it. And also in my research and that of others, we've looked at outcomes of mistrust, potential health outcomes, what's correlated with medical mistrust. So for example, in the general research literature, general mistrust is associated with lower healthcare engagement, greater delay in screenings and other preventive services, lower adherence to medical advice and prescription refills. And in my own research, I looked specifically more at HIV outcomes and finding it's associated with both prevention and treatment, related to condomless sex and PrEP use, as well as treatment outcomes related to adherence to antiretroviral therapy, having a detectable viral load, and weaker beliefs about the effectiveness of ART. And that in turn is related to non-adherence. So people who mistrust in general, have general levels of mistrust around HIV in general, and the system, the healthcare system, are less likely to believe that ART is effective. And that's what's driving the relationship with non-adherence. So there's some preliminary research done on COVID-19 and medical mistrust. Some of my own that I mentioned with APLA Health, but also some here and in other countries, showing that mistrust around COVID-19 is related to less adherence to preventive measures like mask wearing, lower acceptability of future and present treatments, and also higher hesitancy around a future vaccine. So now I'd like to talk in the last half of my presentation around how mistrust can be addressed. So there are currently no evidence-based provider interventions to address medical mistrust. And that's really important to know because we've been asked a lot through CHIPS and also in my other work, can you do a provider training? Is there something that's off the shelf that we can use that's already been tested? And the answer is there hasn't been anything like that we can do. But I think this workshop today, this training today is the beginning of that. And we're saying some of the things that we hope to test in future trials. So there have been interventions around improving trust in one's individual provider. But that doesn't really address trust in the healthcare system as a whole and on trust in medications. So for example, there's trainings on cultural competency, on increasing empathy, increasing patient-centered communication. And some, for example, there was one effective training with oncologists that used intensive tailored patient case feedback, but it required many observations of the patient-provider relationship over a long period of time and giving feedback and having a feedback loop. So it's maybe not feasible overall, and also it increased trust in the individual physician, but maybe not in the system as a whole. And also most of these kinds of interventions have not been effective and none have been tested for HIV. So how can we address medical mistrust? So in terms of patient level interventions, so a few have focused on improving trust in HIV related information and decreasing HIV related mistrust. So I mentioned Dr. Billy Cunningham. He did work on community-based peer navigation for peers for the community to serve as a bridge to healthcare. So trusted peers who had been through the same situations as the clients, for example. Link LA was one of his studies where he had peers meeting people post-incarceration to then link them to HIV care. And that was successful. And one mechanism by which it was successful, we think, was building trust. Also, I've done community-based peer counseling interventions, and these interventions use motivational interviewing, which I'll be talking about in my last slides as strategies from that, also cognitive behavior strategies. And these strategies acknowledge, validate, and discuss mistrust as a justified response to discrimination. So I'll be going through that in detail in the next slide. So now I wanted to discuss more specifically recommendations for providers and start out with psychoeducation, which is a term used in psychology. It just basically means education and support around an issue. And so having education that raises provider awareness about the levels of mistrust in communities and the origins of mistrust and systemic racism, much as how we're doing today, and also provides psychoeducation about how mistrust is related to health inequities and how it can affect healthcare interactions, reduce healthcare engagement and adherence, and affect outcomes. And also discuss how to recognize mistrust verbally and non-verbally. So these are all things we'd like to do today, and also that should be integrated into larger provider trainings. So I want to talk a bit about the signs of mistrust. I think our panel spoke well about this. But so as I mentioned, they can be verbal or nonverbal. It could be lack of engagement in the healthcare interaction by the patient or client. They don't ask questions, they don't make eye contact, seem uncomfortable, don't verbally agree to the behavior, they just take the prescription and leave. So things like this, they might not say, I don't trust anything, but if you look at their behaviors, they might, it might be indicative of mistrust. Or you see their behaviors over time, they're not adhering, they're not coming back, they're missing visits. Or there could be direct statements, and like I said, it might not always be direct statements, but there could be direct statements that they don't like taking the medication, they don't trust the medication. So something like that, where they say something and it's mistrust. So as I mentioned, I wanted to talk a little bit about motivational interviewing. And motivational interviewing is a clinical psychology technique in which it's non-confrontational, non-judgmental, in which you respond in a very client-centered way, patient-centered way. And so using these strategies, I'll talk about how do you use these kinds of strategies now to respond to mistrust in a sensitive manner while still conveying accurate information, because we still want to educate and talk about, for example, the validity, the effectiveness of the medication. But how can we do this sensitively? And the first thing would be to validate mistrust, which I'll talk about on the next slides. And I mentioned being non-judgmental and non-confrontational, asking open-ended questions and getting to know the patient, the client, where they're coming from, and using reflection and reflective listening, asking for permission before you share any information that you might want to say about the medication. And I'll talk about all of these in the next slide. And also having an open figure, making eye contact, being open to hearing what they're saying, just something so simple like that. And I know a lot of people in the training probably know this, but I talked to several doctors, physicians while I was getting ready for this talk and asked them how they do that. And one said, yes, so many of her colleagues, just look at the computer and type on the computer. And she said she's old fashioned. She just gets out a pen and paper and maintains eye contact the whole time so she can take notes. And so thinking about ways we can do that. So I want to talk a bit about validation, and that's acknowledging and affirming experiences of discrimination and expressions of mistrust that a client might have. And so communicating to the patient or client that their thoughts, behaviors, and emotions are well-grounded, justifiable, relevant, and meaningful. So how do we do that? Well, we can acknowledge historical and current context of discrimination and systemic racism as a root cause of mistrust, and reflect back to the patient or the client negative feelings they might have towards healthcare and their concerns. So it shows that you hear them if you repeat what they're saying or you paraphrase what they're saying, and showing empathy, saying, I hear where you're coming from. And here's an example. I'm not saying that you have to use this example verbatim with patients or clients, but it's more that it's an example that has some of these elements so that you can see some of the ways validation, for example, is used. So given the mistreatment that Black Americans have faced, it sometimes makes sense to believe that providers aren't looking out for your best interests. So that validates their mistrust. And there's so many past and current examples of discrimination in the US, especially in healthcare settings where we've heard about unethical medical experiments like Tuskegee, segregation in healthcare, when Black people were forced to get lower quality separate services. So that's where you say, I know where you're coming from. And so it's understandable to be cautious about healthcare providers and wonder if the medications really work. So saying, I know where you're coming from. This makes sense that you would feel this way, so let's talk about it. Another way to validate is to be proactive, and maybe you see a patient might be mistrustful, maybe from their body language, or you're not sure, or maybe you want to do this with all patients, but say something like that shows, you really care about them and the issues. Like we're trying to improve our relationships with patients. If there's anything that I do or say, or that someone at the clinic does or says that makes you feel uncomfortable, would you mind letting me know? And whatever you tell me won't affect your treatment or healthcare. I'll keep it confidential if you prefer. So you can be proactive and solicit this information. I also wanted to mention open-ended questions. That's a key part of motivational interviewing and using reflective listening. This is a way to show you care about the patient holistically. And they're not just a treatment, they're not just a disease, they're a person. And maybe even opening the conversation, saying things that might give you a clue to how they're feeling, like, hey, hi, how did you sleep last night? Or I talked to a provider who said, she'll open it by saying, how'd you sleep last night? Or she says, who do you live with? Or what do you do for fun? All of these things show that you care about the patient, but also give you clues about, well, if they say, well, I live alone, I didn't sleep well, I don't do anything for fun, it's really hard in these times. It helps us all understand where that patient is, where they're coming from, so that you can understand everything else that follows in the interaction, and then fully hear their concerns. Another technique in motivational interviewing is reflection and rolling with resistance. And this leaves room for patients to say the concerns in their own words. For example, why they don't want to do something, and then reflect these concerns back to them. So they say, I don't want to take the medication. And you say, so you don't want to take the medication? Let's talk about that. So you open the conversation. And this is where people really have to hold back their writing reflex and allowing them to make their own decision and not telling them what to do. because you're not going to go home with them and you're not going to follow them and watch them and make sure they take those medications or make sure they do what you said. You know, so they have to make their own decisions. And obviously a lot of people know that, but it's also sometimes hard not to hold that back. So here's another example of asking for permission after validating. So it sounds like you don't trust HIV treatment. Would it be all right if I shared some information with you about the treatment and you can tell me what you think? So that first sentence, so it sounds like you don't trust it, is validating. And then you're asking for permission to share more information. I won't read this whole thing, but what I wanted to point out is this then validates, you know, and acknowledges mistrust and where it's coming from. And then at the end saying that you actually know people, you know, this can be very convincing. You know people have been mistrustful. In fact, I had a patient recently who did not initially trust the medications, but decided to give them a try and is now undetectable. So that's something, you know, that can be very convincing to say I know patients just like you who have these concerns and we talked about it and, you know, they ended up getting better, or, you know, something like that. Another example of open-ended questions is to ask use hypothetical language, because that could be less threatening than asking directly. Something like, why don't you do this? No, instead you might want to say, what might it take for you to take this treatment or vaccine? And it encourages them to discuss the reasons why they might want to engage in the behavior. So maybe they realize, well, it's really consistent with the fact that they want to remain healthy and they're a bit ambivalent about it. They just don't know whether to trust it. So you can reflect those reasons back to them. And then they hear in their own words, the reasons why they should take the vaccine, for example, or the treatment. So those were my recommendations for providers. And I know we don't have much time, so I'm just going to mention a couple things, as I mentioned before, that I think it's really important to think about structural change in this context as well. Because if we're just focused on changing individual providers' behaviors, we're sort of missing the larger picture. And it could be that providers are really great and everyone trusts them, but the mistrust is still there because the organization as a whole is not trusted or is doing things that making people not trust that organization. So as providers, we can all call for change in healthcare organizations. So these are just some examples. I really would love people to write in the chat box more examples. These are kind of talking to people off the top of my head. This is not a comprehensive list, it's to get a discussion going. But for example, providers could encourage healthcare organizations to engage with community stakeholders, like on advisory boards. A lot of healthcare organizations may say, hey, we already did that, we checked that box, but are they truly engaging? You know, hold them to task. Are they just saying, sure, we talk to some stakeholders every once in a while? Can they point to changes they make as a result of what stakeholders have told them? And one thing they could also do with community stakeholders and with providers is reviewing patient data and policies around disparities and inequities. And if they do find disparities in treatment, they can develop an action plan and work with the community to do that. There's also, I know a lot of you know, there's a lot of talk about diversifying the healthcare workforce and the pipeline of people into healthcare. And one example might be to also train community members to perform medical assistant duties that don't necessarily require medical training, like for COVID-19, maybe some symptom screening or consenting or explaining new treatments and vaccines. I'm almost done. I think I just heard the alarm. So the other thing I wanted to mention is also in terms of structural change is recommendations for communities. And one example would be harness those positive effects of mistrust that I talked about earlier. So mistrust can be effective if it's harnessed correctly. So for example, it can catalyze individuals for change to be, for example, informed healthcare consumers. People can find out about their local organizations and how they're doing, what their care quality is, or are there any inequities or disparities? And do they have community engagement policies? So we can find out also as consumers. And also my plug for civic engagement, just in the larger scheme of things, you know, voting, encouraging others to vote, taking the census, especially at this time, you know, and those things can lead to change as well. And people can be empowered to do those things. And also to engage with local elected officials, for example, in local town hall meetings, and keeping them to task, asking them about their policies and what they're doing around anti-racist policies. So I just want to say I would love to hear people's ideas for anything I said, but also in the chat box if people want to write recommendations for change in healthcare organizations and communities around structural change, that would be great. I think if we got a great list going, we could even compile it, disseminate it, and would love to hear your ideas. So I'm going to leave with that, and the next thing, and you can continue writing in the chat box, I hope people are, but I wanted to introduce Dr. Sai Takata, who's going to show a brief video